Thanks, Josh. Thanks, Yvonne, for sharing your story. I can probably vouch for everybody in this room that nobody goes to work with the intent of doing harm. And when that happens, it does take a toll on everyone. I am a registered nurse in the PACU at a major healthcare system in Cleveland, Ohio. I sound like a contestant on Wheel of Fortune. I am not speaking on behalf of the Cleveland Clinic, but I am employed at the Cleveland Clinic. And I have been in the perianesthesia setting for 40 years. It's a big year for the 40 years celebration. I began speaking on opioid safety prior to the pandemic when we realized we had a problem in our hospitals and our community, and it was very prominent in the news at the time. I chose to work at the hospital that I'm at. It's a regional hospital of the Cleveland Clinic because it is in my community. It's in my community, it's in my neighborhood. I serve my friends, my kids' friends, my patients. I know, I see them at Target, I see them at the store. So when this was coming to light, I was fortunate enough to be approached by two of our anesthesiologists, Dr. Mark Taylor and Dr. Eric Chang, that said, we need to take this education out and awareness out to our caregivers. Well, within the Cleveland Clinic health system, we were able to touch thousands and thousands of caregivers talking about opioid safety in perioperative settings. So then 2020 came, we spoke nationally, we went to communities, we did I thought a really good job of raising awareness about opioid safety. And we didn't really just talk about opioid use and misuse, but we did talk about the dangers of using opioids. And what I learned is that nurses play a critical role. In the PACU, we can always find nurses vigilant at the bedside, and we can always blame the system. But I came to realize that I, as a nurse, am part of that system. So what was I doing to change my practice, to protect my patients, to prevent harm for my patients, when our everyday use of opioids was so high? When I was an educator prior to this role, and when we orient people, one of the hardest things to teach a nurse coming from even an ICU setting or a med-surg floor is the amount of pain medication we give in a short period of time in divided doses. And it's a lot to wrap your head around. We do over in the enterprise 250,000 surgeries a year. That's a lot of pain management and a lot of medication. So, oops, sorry. Let me see. So I promised them I wouldn't show graphs, but this is my favorite graph in the whole world. It's a graph in 2022. It'll probably be the same graph in 2023 from Gallup. We've only fallen off the top spot, nurses, once, and that was in 2011 when the firefighters took our spot, and rightfully so. We are the most trusted profession, and with that comes a lot of pride, and I feel a lot of responsibility to prevent harm and to do what's best for our patients. So when we talk about attributes and skill sets that nurses have, we always look at the technical skills, the clinical judgment, the assessment skills, the ability to do two things at once, which we know is not always safe. Just being versatile, being able to, I can start my day in pre-op, we're all cross-trained, I can go to post-op, I can send patients home, I can take the ICU patient. Those are all really good, valuable skills. But the one that's least mentioned is the one that I feel is the most important, and that's the role of advocacy. When a patient enters the healthcare system, especially today, you need a navigator. You need someone that's going to speak for you when you can't speak for yourself. If I work pre-op, there isn't a day that goes by that a patient, and we see a lot of patients, would say to me, please don't let anything happen to me. And I assure them they're in a safe place, and I do my best to advocate for that patient. But I am conflicted. Remember that at the same time, I have an ethical responsibility to manage their pain. That's from the ANA, that's from our nursing, that's from our soul. We don't want to see people suffer. So how do we weigh that responsibility to manage pain and the dangers of pretty much what we're doing to do that? There is nothing I want to do during my time with that patient to betray that trust. We didn't get that top spot, and I'm not boasting. We did not get that top spot because people don't trust us. So if I have a recovering addict come in and he says, I really, really don't want anything that's going to show up in my drug screen or put me back on that path. I work really hard with our anesthesia team. I work really hard with him or her surgeon to kind of come up with a plan. Does it always work? I have the same frustrations that you do. What do I do in the moment? It's really hard. It's episodic care. I can't follow that patient all the way home. So some of the challenges I face as a perianesthesia nurse is the limitations of the pain assessment tools we have. We know the gold standard is 0 to 10. We know that my order sets are then accompany that, and I can only give pain management in the state that I practice. I can't go off those ranges. I can't say, well, I think Tylenol would work here when I have an order that reads, if the pain is 0 to 4, you must give. I can work with that and try to get another order and do what I need, but that is a limitation of the pain assessment tools that we have. I don't believe that the risks of opioid administration are communicated to our patients. I have friends that work in oncology, and you better believe before you start a chemotherapy plan, you are given every risk and benefit before you start that medication plan, and you're usually counseled by our pharmacist. I don't think our patients know. In one study, they showed that like a third of the patients did not even realize that what they were taking were opioids. We are under the same production pressures and clinical workload that all of us in this room are. We're asked to do more and do it faster. I never intend, and I apologize all the time, to put the OR on hold. We never intend that. But we have a workload in that room, and it's like a throughway. It is people coming and going. I'm trying to do all this in a very distracted environment, and yet I'm very aware of the throughput of trying to get out of the OR so that the other people can get in, and that's the environment which we work. I may only have 2 patients. We have, our professional society has staffing guidelines. I should only ever have no more than 2 phase 1 PACU patients, and I'm proud to say I work in an institution that they hold us to that. But even managing 2 people at the same time is difficult. I also have standardized order sets, which I'm sure everybody does, and it solved one problem and kind of created another. We don't really customize those order sets per patient. And sometimes I don't advocate for that as well. There is a lack of education in pain management for medical professionals, and I'm going to say for nursing. I did not get any, and I trained a long time ago, but I also taught nursing. We teach pain management about this much, and we don't do it well. I don't know, in the area of anesthesia, you may have much more robust training, but it's usually by experience and trial and error. And then we don't have a way to manage our patient expectations. We all see what patients are exposed to. They're a little more aware of the risks of opioids, but they don't really know what their options are. And if nobody's offering them other options, opioids seem to be the easy choice. We have lack of consistent standards and guidelines and equipment for monitoring. We have position statements. I don't even want to talk necessarily about capnography. My colleague and I just authored a position statement on the use of capnography in the PACU, but we're using words like consider. We don't have you must, and sometimes nurses would like you must, then we can follow that. And then how do we treat, coming out of this addiction or still living in it, how do we treat patients that are recovering addicts? we don't really have a lot of science that tells us the best way to do that. Sometimes, unfortunately, we don't even know that that's part of their history until they present for surgery. But I don't want to only talk about the challenges. We have done great things in the area of, in terms of medication safety and error prevention. There's legislation that has helped us. There's right sizing prescription guidelines. I always tell the story of a resident that was in my carpool. So I'm a little bit older, and he was an orthopedic resident. And he was sending my 90-year-old patient home with a wrist fracture with 90 oxycodone. And I felt comfortable in the moment to say, Kevin, what are you thinking? What are you thinking? I don't know. They said, do this, you know, he's managing his workload. But if nobody questioned it, that lady would have walked out the door with that prescription. And then we know that those extra medications are ripe for misuse. Safe medication disposal programs, we have those in place now. Part of my research was sending every patient home with an opioid disposal bag that, in following up with them 30 days later, the results were abysmal because people weren't willing to part with it in the time of limited prescribing. We have opioid-free anesthesia. We have different techniques we can use and offer the patient. And we do have some consensus statements and guidelines that guide us. Barcode medication administration. Thank you, ISMP, that when I was an educator, we fought, everybody said the package, it's too busy to do barcode medication administration. We give a ton of partial doses. I manage those two patients. I may be medicating them at the same time. I love barcode medication administration. It's a layer of safety for me. And when nurses train under that in different divisions and they come to the PACU and we didn't have it, we really removed a layer of safety that needed to be there. We have pharmacy collaboration where I work. We meet regularly with them. We talk about what our concerns and our problems are. We have EPIC, and one thing in the system is we could not release our medications until they arrived in the PACU, and then we had to wait for pharmacy to verify them, and that sometimes took a little bit of time, and we'd have a patient that was screaming in pain. So we worked on that process to correct that. We removed compounding and mixing at the bedside based on ISMP guidelines because we were mixing our own ephedrine and neo from an IV bag not too recently. I should have been concentrating on supporting a hypotensive patient, not mixing medications. We've changed all that. So there is good work being done. And if a medication error is made, I work in a place where I am very safe and I feel very supported. And we have peer support programs. And I'm really proud of that. People are not afraid to talk about them, but I'm not sure what constitutes a medication error. Is a medication error, Paul will talk about it maybe in a legal sense, but is it omission? Is it because, am I giving opioids to someone that does not know the risks and benefits and then probably sending them home with them without necessarily any monitoring? Am I giving them things that can cause harm down the road? That's where I struggle. And in a fast-paced environment where we need to keep moving and we have that inherent pressure to do more and do it faster, is it easier to give an opioid than sit at a bedside? Probably. Do I have to do everything I can to maintain that patient's trust? Absolutely. Thank you.